Hello, doctors. This is Dr. Brony here. And I'm hoping that we can have a wonderful time today. I'm really, really excited, for today's class because we're going to delve deep into a topic which a lot of candidates really, really struggle with. Please let me know. Let me know, where are you joining me from? Where are you joining me from? Just let me know right away. Just type where you are joining me from and let's take it from there. Where are you joining me from, please? So doctors, please, let me know, where are you joining me from? Where are you joining me from? Oh my goodness, I'm excited. So Dr. Escaravi, we are getting a lot of, doctors. So please make sure you are sending this to as many friends as possible, okay? It's exciting, it's powerful, it's great. I'm here to make sure that we do the right thing, and I'm here to make sure that, we enjoy ourselves. So please make sure you are sending this link to so many of your friends. I've seen some people liking our YouTube and Facebook button. Please, as many of you as possible, just go to YouTube and then just click on like, subscribe to MedCognito's portal right away. Subscribe. Okay, let's get to 1,600 subscribers today. And please don't forget to also share the link. Share it with as many friends as possible. If you have any Telegram group, share there. If you have any WhatsApp group, share it there. If you have any Discord group, share it there. We are here to make sure that, we get the best out of our studies so that we can really, really prepare for this upcoming exam. You know that there's been a lot of change in the exam. So I want to get you going. This is Dr. Brony, and someone is asking, does the class begin soon? Yes, doctor, we are about to start, okay? And we have many people join us, some from Ontario, some from Pakistan. Beautiful. Dr. Jagdeep is joining me from Brampton, Ontario. So doctors, let's get the numbers going. So we can get as many people. Oh, Dr. De Facto is joining us from Quebec. And Dr. Simbiat is joining us as well from Ontario. We have some people join us from Saskatoon, Ontario. So doctors, please make sure that your province is well represented. North Vancouver, beautiful. So look, it's been awesome. And I'm very, very happy that we are all joining in today. So let me just jump right in so we can get the ball rolling, okay? So please, before we get into the class today, always remember that apart from MCCQE1, MedCognito offers other things, so many other things. So currently we have our MCCQE1 promo going till December 31st. So you have 2 days more to go. So if you've not jumped in, please do well to jump in, okay? And we also do the NACOSKI prep. A promotion is also going on till December 31st. If you go to our website, you'll see it there. We also have the TDM going, and the promotion is going on till December 31st as well. And we have MMI, as well as the CAMS and CV and personal statement preparation, and one-on-one interview prep for CAMS and PRA. So doctors, it's exciting. I hope you had a wonderful Christmas, okay? And I hope you are enjoying time with the family, because that's the most important thing. That's the most important thing for us. So today I'm going to just jump in, and we're going to do a deep dive into a very, very important MCCQE1 topic that you need to know, okay? We're going to dive deep into this topic, because for me it's very, very critical. Approach to headaches. So someone may ask, hey, Dr. Brony, why are we doing approach to headaches? Why are we doing approach to headaches? I'm going to show you the reason why we need to do it. The Medical Council of Canada wants you to know, all right? They want you to know. And because of that, as we learn all the time, today we're going to dive in. And the headache presentation basically is talking about, you need to know your rationale. You need to know your rationale. And doctors, some people say they can't hear me. If you can hear me, please just type yes. I want to know that you can hear me before I move on. Please Type yes. I want to know that you can hear me before we can move on. Please type yes. Yes. I want to make sure you can hear me because somebody just sent me a message that Dr. Boni, I can't hear. Okay, good. Good. So Dr. Misbao says he can hear me. Dr. De facto says he can hear me 100%. Beautiful. Okay, that's awesome. So we can move on. So, doctor, if you can't hear, that means probably there's something wrong with your machine or something. So please check the settings on your laptop and let's get it going. Okay, so why are we dealing with headache? Remember that whenever we are studying, I always say that in the MCCQE1 exam, the exam is at the level of a medical student. If it's at the level of a medical student, what does the medical council want you to know, right? So the first thing, which is the rationale which you need to know, is that headache is a common clinical presentation, and patients with headache due to serious or life-threatening conditions must be differentiated from those with benign primary headache disorders. So, doctors, I have a question for you. This one, we've been doing it every single time we meet to study. Why do you think, what is that one word? What is that one word you think the medical council was like, of all the topics in the exam, the doctors need to also learn about headache? What is that one word? What is that one word which has featured and features all the time? What is that one word? Please let me know. I want to see what you say. What is that one word? Please type it in the comment section. Beautiful. Dr. Sabine says here, common things. So the word we need to know and why this topic has featured in your MCCQE1 preparation is common. Okay, so patients with headache due to serious or life-threatening conditions, okay, must be differentiated from those with benign primary headache disorders. In other words, if you are learning this objective, you've got to ask yourself, of all the causes of headache, which of them is life-threatening and which of them are benign? That is where you start from. And if you're able to get that right, then you are on good ground. Okay, so let's go to the causal conditions. And you realize that the medical council always states something, that the list is not exhaustive. Okay, so what are they actually saying? Remember, we talked about primary headaches and life-threatening headaches. So the primary headaches you need to master will be migraine headaches. So if I were you, I'll write this down that, look, I need to master migraine headache. I need to master chronic daily headache with medication overuse. So medication overuse headache. And those in MedCognito, you will realize that if you go to your neurology portal, we've done a whole lecture series on all these things for you. Okay, so this morning somebody was asking me, Dr. Boni, how do we prepare for the class? All you needed to do was to go to neurology and then review all the headache concepts there. Number 2, you need to know secondary headache. So you need to know headaches associated with vascular disorders like severe arterial hypertension, headaches associated with non-vascular disorders like patients who develop intracranial infection. And examples of intracranial infections can be meningitis, encephalitis, cerebral abscess, those things. And then you must also learn headaches which are associated with systemic viral infection, headache as a result of carbon monoxide exposure. So doctors, please, you can see that this is very important. This is very critical. Very, very critical. So I want to know, doctors, if you were supposed to learn for this topic, now you realize that the medical counselor has broken everything down for you. First, make sure that you've mastered migraine headache. And whenever you are mastering any topic, I always say that there are 6 things you need to know: clinical features, differential diagnosis, investigations, management, complications, and indications for referral. So every topic you are learning. So if you pick something like migraine headaches, okay, what you have to ask yourself is, what are the clinical features of migraine headaches? Number 1. Number 2, what are the investigations I need to do? Do I even need to do any investigations at all? Right? Number 3, how do I manage a patient with migraine headaches? Number 4, are there any complications? Number 5, what are the investigations I need to do? And number 6, when do I refer a patient with suspected migraine headache to a neurologist? You do the same for medication overuse. You do the same for patients with, severe arterial hypertension. You do the same for patients with meningitis. You realize that with meningitis, you need to get your lumbar puncture, you need to give your antibiotics, you need to isolate the patient, you need to even know, when do I give prophylaxis to patients who have been exposed to this particular patient with meningitis, right? You need to know, if somebody has carbon monoxide poisoning, how will they present? Doctors, please, I've just given you so much information right now. If you are following me, just type following, Dr. Brony. I am following. Today we are going bonkers. Today we're going to break the bottles on headache and make sure that we get it right. So please, before I move on from this slide, today we have quite a number of things to study. But before I move on from this slide, please, if you are following what I've just said, just type following, so that I will know that you are really following me. Beautiful, beautiful, beautiful. I like the energy. So, what are the key objectives here? Giving a patient with headaches, the candidate will diagnose the cause of the headache, the severity of the headache. Remember that I was talking about all that. If you've learned QE1 over and over and over and over again, you have to have all these things at your fingertips, right? Because I've been going through these things with candidates for years, right? So, giving a patient with headache, the candidate will diagnose the cause. What are the various causes of headache? The severity, complications, and will initiate appropriate management plan. Now look at something here. Particular attention should be paid to differentiating benign causes of headache from potentially serious causes. And for me, this is very important. Very important. Particular attention should be paid to differentiating benign causes of headaches from potentially serious causes. So, doctors, in the comment section, tell me, each doctor should type 2 severe or serious causes of headaches and 2 benign causes of headaches. I want to see right now. Please type it in the comment section. 2 benign causes of headaches and 2 serious causes of headaches. Okay, just type it right now. 2 benign causes of headaches, 2 serious causes of headaches. 2 benign causes, 2 serious causes. Please type it right away. I want to see. Okay, so now, Dr. Ronnie, you typed subarachnoid hemorrhage. Please, is that serious or benign? I want to know. Let me go to Dr. John, Dr. Umwa Amazing John, and she's awesome. Very serious student. She says brain abscess and meningitis. Serious. Beautiful. Now, let me go to Dr. Maria Osman. Migraine, tension, headache. Benign. Beautiful. Let me go to Dr. Sabine Amjad. Says benign are migraine and tension headache. Beautiful. Let me go to Dr. Nargus Escarvi. Benign, migraine and tension. Great. Dr. Adewunmi Adiola says benign causes are migraine and tension. So look, we have so many answers coming through. Benign cluster. Dr. De facto, you said hypertension and anemia. I don't know what that will go for. So if you can qualify, that would be great. And then Dr. Ufunenya says subarachnoid hemorrhage, giant cell arthritis, severe. Okay, we have cerebral abscess, CVA. Beautiful. Look, today the participation is through the roof, and that is great. Okay, so now let's move on. So the enabling objectives. Given a patient with headaches, the candidate will list and interpret critical clinical findings, including symptoms and signs that indicate a need for urgent brain imaging and or referral for specialized care. And number 2, symptoms and signs to differentiate amongst the various causes of headaches. So doctors, 2 things here. Like I've always been saying, those 6 things, So when you're learning headache, you've got to ask yourself, what are the symptoms and signs that indicate a need for urgent brain imaging, okay, or referral to a specialist? What are the things you will see which should tell you that, no, this patient needs to go to see the neurologist right away? I need to call for an urgent head CT scan, or I need to call for an urgent investigation. Number two, how will I separate migraine headaches from cluster headaches, from medication overuse headaches, from headaches as a result of pseudotumor cerebri, from headaches as a result of pheochromocytoma? How will I do this? Unless you've equipped yourself with these things, you will never be able to ace this topic. Now, another enabling objective is list and interpret critical investigations, okay, including appropriate and cost-effective laboratory and diagnostic imaging tests. So what investigations will you do for a patient with headache, depending on the differentials you're thinking about? And then you need to know indications and contraindications for lumbar puncture. So those in MedCognito as well, go to neurology portal, go to headache. You will see that we've done all this work for you. It's just a few minutes and you can just bam, 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 bam. You are done. Okay, good. We continue the enabling objectives. It says, construct an effective management plan, including describing and contrasting symptomatic and prophylactic measures, or treatment. So if you have a patient with headache, how do you contrast symptomatic and prophylactic treatments? If somebody comes in with migraine headaches, how will you manage the patient actively, the symptoms? And then what prophylaxis will you also give? How are you going to avoid medication overuse? And how are you going to determine if a patient needs an urgent specialist care or the patient can be sent home? Okay, and educating and counseling the patient regarding the causes and management of headaches. All right, and as well determining if the patient is at risk of narcotic addiction or overdose. So these are the things. Unless you've covered all these, doctor, you have not covered this objective. And all of these have been covered for you in your MedCognito portal. And today, we're going to pick on some very high yield stuff and go through them. But before we continue, like we do, today the class is going to be a bit different because I was quizzing the MedCognito students this morning in our WhatsApp group. And what I realized was that some people were doing guesswork. So today it's going to be a mixture of MCQs and you being able to tell me the diagnosis without me giving you options. So doctors, so today is going to be a drill. I'm going to really, really drill you. So please, let's take the first MCQ question. I'm going to give you the first MCQ question. And this is the first question. The first question goes like this. A 28-year-old woman presents with a 2-day history of unilateral throbbing headache. We'll start thinking about it. Female, 2 days, unilateral throbbing headache. This patient reports nausea and sensitivity to bright lights and loud sounds. She also notes that her headache is aggravated by walking and other physical activities. There is no history of similar headaches in the past. What is your most likely diagnosis? A, tension headache. B, migraine headache. C, cluster headache. D, sinus headache. 28-year-old woman, 2-day history of unilateral throbbing headache, nausea, sensitivity to bright lights and loud sounds. She also notes that her headaches are aggravated by walking and other physical activity. There is no history of similar headaches in the past. What's the most likely diagnosis? A, tension type headache. B, migraine headache. C, cluster headache. D, sinus headache. Let me see the answers you guys are giving me. Oh my goodness. It looks like B is the overarching thing because Dr. Anastasia says B, Dr. Sabine, Dr. Sukrin, everyone, Dr. Aaron Smith says B, Dr. David says B, Dr. Shankar says B. Everyone is going for B, 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 B. It seems everyone is going for B. Okay. So what's the correct answer? The correct answer is B. The correct answer is B. Why is B the correct answer? You know, the patient has unilateral throbbing headache or pain, photophobia and phonophobia, nausea, and it is aggravated by physical activity. All right. And these are classic features of migraine headache. The duration of 4 to 72 hours also aligns with this type of headache. Now, by the way, why is tension headache, cluster headache, and sinus headache wrong? So tension headache is usually bilateral. So doctors, please use this question to start mastering how you're going to differentiate migraine from cluster and from tension headache, okay? So tension headache is bilateral. It is mild to moderate. It is non-pulsatile. So please write these down. Without nausea or light sensitivity. Doctors, please. Are we all on the same track? So that's tension type headache for you. What about migraine cluster headaches? What about cluster headaches? Cluster headaches are severe and they feel like stabbing pain, around the eye. So whenever you see a question stem, you want to look at where they are saying the features are. And there are autonomic symptoms like ptosis or conjunctival injection. So that is cluster headache for you. So learn about migraine, unilateral, throbbing pain, photophobia, phonophobia, nausea, aggravation with physical activity. Okay, look at the duration as well, which you are given. And then now go to tension, go to cluster, and then sinus type headache, as in headache as a result of sinusitis. This is pain where the patient has sinusitis symptoms like fever, purulent nasal discharge, dull pain, not throbbing. Okay, so that's for the first question. It looks like so many people got it right, so that's great. Let's go to the next question. You have a 35-year-old male who presents with severe headaches occurring every night for the past week. The pain is sharp, stabbing, and localized to the left eye, lasting about 60 minutes. He also reports tearing of the eye and nasal congestion on the same side. He feels restless during the episodes. What's the most likely diagnosis? A, migraine headaches. B, tension type headache. C, cluster headache. D, sinus headache. Doctors, what is your answer? By the way, while you're answering this, please make sure you are liking and sharing our YouTube and you're subscribing to the YouTube channel, okay? Because if we're able to grow the YouTube channel, then it makes MedCognito more visible and other doctors from all over the world can also see it, right? So doctors, what's your answer here? Headaches presents every night for the past 1 week. Pain is sharp. Pain is stabbing. Pain is localized to the left eye. It lasts about 60 minutes, okay? There is reporting of tearing of the eye and nasal congestion on the same side. The patient feels restless during the episode. What's the most likely diagnosis? I see that a lot of doctors are going for C. Many people are Dr. Kano went for C. Dr. Heiner says that the patient is restless during the headache, and then there's congestion and all those things. She thinks it's cluster headache, and the answer is cluster headache. So doctors, we've learned about features of migraine. Now we are using this question to learn about features of cluster headache. So the severe unilateral pain, remember that word, unilateral pain around the eye, around the eye, short duration, 15 minutes to 180 minutes with autonomic symptoms. Okay, so like tearing, nasal congestion. The patient is restless. So, like what our dear doctor said, that suggests cluster headaches. Why is migraine headache wrong? Migraine is usually throbbing, it lasts longer, and it's associated with nausea or aura. So that's not migraine for you. What about tension type headache? Mild to moderate headache, right? Bilateral. It presses, it causes pressing pain, and there are no autonomic symptoms. That's tension type headache for you. And we've already read about, sinus headache or headache as a result of sinusitis. So I'm not going to waste your time. Let's go to another question. So, doctors, please, before we move on to this question, I have a question for you. Is it making sense now? At least, are we able to break down migraine headache, cluster headache, migraine headache, cluster headache? Are we breaking it down? If we are breaking it down, please let me know. Yes, 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 yes. If we are breaking it down, let me know, so that I'll be able to know how you really, really want me to go around this. If you feel that we are breaking it down, beautiful, 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 beautiful. That's great. Okay, so now let's go on to the next one. Let's go on to the next question. You have a 45-year-old woman who reports a 3-day history of bilateral headache. She describes the pain as tight and around her head. The headache is mild and not associated with nausea, vomiting, or sensitivity to light or sound. It is not worsened by physical activity, was the most likely diagnosis. 3-day history, bilateral headache, it feels like a tight band. A, migraine headache. B, tension type headache. C, cluster headache. D, sinus headache. What is your answer, doctors? What's your answer? Is it A? Is it B? Is it C? Is it D? Looks like a lot of doctors are going with tension type headache. Looks like a lot of doctors are going with tension type headache. And I see a lot of answers. Everyone is going for B, B, B. And that is tension type headache. Tension type headache is characterized by bilateral, mild to moderate pain with a pressing or tightening quality, right? Usually it lacks the features of nausea, vomiting, photophobia, phonophobia. It is not aggravated by activity. So that's tension headache for you. So today, before we dive deep, doctor, this is just the introduction. So please, if you feel like we are just wrapping up and we're going, no. This is just the beginning of the game. So if you are hungry, ask your wife or your husband to bring you some food, or ask your daughter to bring you some food, or ask them to bring you some juice. Because today we're going to stay on and learn a lot. All right. So tension type headache is usually characterized by bilateral, mild to moderate pain with pressing or tightening quality. All right. It lacks features such as nausea. It lacks features like vomiting. It lacks features like photophobia or phonophobia. And it is not aggravated by activity. So that is tension for you. So today we've learned migraine, we've learned tension, we've learned cluster. Now, what I'll do is I'll just take you through this, the primary headache disorders quickly, so that you can all be able to master it right away. So let's go to tension. We've learned it already, but I'm just summarizing everything. Tension, 30 minutes to 7 days. Bilateral, okay, pressing or tightening. And the intensity that is mild to moderate. That's tension headache for you. Sorry, I have a small cold, so you can hear it in my voice. Other features of tension headache is that it is not aggravated by physical activity. There is no nausea or vomiting. Okay, there is no sensitivity to light or to sound. So that is tension type headache for you. Tension, 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 tension. Doctors, so if you are sleeping and Dr. Bruni wakes you up, like the way I wake up the MedCognito students to wake up to study, you should be able to know features of tension headache. Now let's go to migraine headache. Let's go to migraine headache. Usually the duration of migraine headache is 4 to 72 hours. 4 to 72 hours. Usually migraine headache, the location is that it is unilateral. It is throbbing or pulsatile. All right. And it is often associated with aura in some cases. And it is aggravated by physical activities. And it is accompanied by photophobia and phonophobia. And the patient may have or may not have nausea or vomiting. So look out for these features in your MCCQE1 exam prep. Okay. And whenever you see it, go like, I know, this is migraine headache. I got it. This one is migraine headache, and I'm not going to miss it at all. Okay. Now, you have to also know that when it comes to migraine headache, there are some triggers. And the reason why I'm going deep in this is because the exam is changing. And if the exam is changing, initially it was MCQs and CDMs, but now you are going for MCQs alone. And one thing with MCQs is that you can't just go into MCQs with surface knowledge, right? You've got to go deep. So what are dietary triggers of migraine headaches? Alcohol is one of them. Chocolate is one of them. If the patient has been taking aged cheese, it's also another one of them. Monosodium glutamate is also one of the triggers, dietary triggers of migraine headaches. Aspartame, okay, it's usually put in food to sweeten it, especially in patients who don't need glucose or who don't need to add sugar to their food, right? Caffeine, nuts as well, nitrites and nitrates. These are dietary triggers of migraine headaches that you need to know for your MCCQE1 exam. Okay, now let's go to hormonal triggers of migraine headache. So you can have patients who are having their menses, okay, or ovulation, or they take progesterone. So please note these 3 hormonal triggers of migraine headaches: menses, ovulation, hormonal replacement like progesterone. So if you see hormonal replacement like estrogen, you go like, no. I remember that in the class, Dr. Brody talked about progesterone. Then sensory stimuli for migraine headaches can be strong lights, right? Strong lights. So like the patient, I'm just going to put on my lights briefly so you see it, right? So strong lights on my phone. So if the patient sees strong lights, they may have some form of headache. If they even have flickering light as well, okay? Flickering light can also be a problem. And then if they are exposed to severe odors, bad smell, or like very strong smell, okay? Very strong smell, very strong smell, that can be a problem as well for them. Very strong smell. And as well as sounds, patients who hear a lot of sounds, sounds can be a trigger, sensory stimulus for migraine headaches. And then excessive sun exposure. Doctors, why am I doing all this? Because the exam is changing. We're going for MCQs alone. And if we're going for MCQs alone, we need to know our stuff deep. What about stresses? There are some stressful things which can trigger migraine headaches. Stress, which can trigger migraine headaches. Number 1, if the patient has times of intense physical activity, or a patient who has just had a loss, like a death in the family, like separation, maybe the place of work, there's a job change, or the person has just been fired from work and has suddenly started developing headaches, or if there is divorce, okay, or if the patient is moving from, say, Saskatchewan to Vancouver, finally, and the person is leaving Saskatchewan for good, moving from one place to the other, or if there's a crisis in the person's life. These are all triggers of migraine headaches. What about changes of environmental habits or environment or the habits, which you must also know for your MCQE1? So if the patient is skipping the meals, if there's been a change in the weather, so like from summer and then all of a sudden we are in winter and it's so cold, that can also be a trigger for migraine headaches. Dehydration, irregular physical activity. Okay, today the person exercises, tomorrow the person does not exercise. Today the person exercises, tomorrow the person does not exercise. Irregularity. Crossing time zones, because we are in Canada, and even in Canada, there are different time zones here, right? And different seasons, as well as, altitude. And if there have been schedule changes, maybe the person was usually working in the mornings and all of a sudden the person has to work in the night, in the morning, go to the afternoon, shift workers, right? Good. And altitude, if the patient goes to a high place, like on mountainous areas, and sleeping patterns, which are also not regular, as well as patients who are dieting. So that is quickly for migraine headaches. We've learned the features of migraine headaches. We've learned the triggers of migraine headaches. Now let's talk about cluster headaches. Cluster headaches. Doctors, please, before we move on, did the triggers of migraine headache, did it make sense? Did it make sense? Please, if it made sense, just let me know. Did it make sense? If it made sense, just type made sense, made sense, made sense. Just type made sense. If it made sense, just type made sense. Before we move on, if it made sense, just type made sense, Dr. Bonnie. It made sense to me. It did make sense to me. It made sense. Okay? It did make sense because I don't want to rush through anything. Today, I want to make sure that we take our time to break down the concepts of headache very, very well. Good. Someone says made multiple sense. Beautiful. Someone also says, yes, made sense. Okay, good. So now let's go on. Cluster headache. So with cluster headache, you're looking for a presentation 15 to 180 minutes. That's 15 minutes to 3 hours. Usually it's around the eye or the temple. It's stabbing. Okay? It's really severe. Really severe. And other features is that it can be ipsilateral autonomic symptoms. The patient can have facial sweating, conjunctival injection, nasal congestion, rhinorrhea, ptosis or meiosis, restlessness or agitation. So these are the features of cluster headache that I want you to master. Features of cluster headache. Which headache usually comes with autonomic symptoms like facial sweating, conjunctival injection, cluster headache. But doctors, you know what? As I said, today we're going to have a long class. But I want to let you know that the recent news we got from the QE1, some of our friends from Nigeria and Iran and Egypt and Pakistan and India are killing it. South Africa, they are killing it for us. So this guy, he's called Dr. Idris. It's called 301. I was like, this is crazy. This is crazy, right? 301. So what are our students saying? Dr. Idris killed it. 301. So doctors, I'm just letting you know, if you prepare well for the exam, you reap the benefits, right? 250 is possible. 267 is possible. Another news from India. This doctor sent me a message, Dr. Brony, I have passed the QE1. Thank you so much for the guidance. I was like, yay, score. She got 250. Okay. What I'm trying to let you know is that everything is possible if you put yourself to it. So, and then another news from India. Thanks for your guidance and your efforts. You did it. And then I asked her, how did you use our resources? Listen to what she said. She said, I made note of all your videos in my notebooks. I studied them 3 times before the exam. I did 100 med bullets twice and gave all the mock tests. Everything is awesome. So this doctor, as the time she was writing the exam, we had only 100 med bullets. Doctors, now we have more than 275 med bullets. And you ask yourself, what is med bullets? Dr. Bruni, I just heard about med bullets. Med bullets is something unique in our family medicine portal. Okay? We review 10 topics per med bullet. So if this doctor says she reviewed 100 med bullets, that means that she reviewed 1,000 topics. Currently, we have 275 med bullets. That means we have 2,750 med bullets in family medicine alone. We are not talking about the other areas here, just family medicine. And med bullets is like, your high yield, quick revision topics. So within 10 minutes, you'd have reviewed 10 topics. And that's how she aced the exam. So, doctors, let's move away from the good news and let's come back to headaches. So, how are you going to evaluate headaches? Because for me, this is very important. How am I going to evaluate patients with headaches? Remember that when we're doing the MCQ1 objectives, the medical council said that we need to know critical and non-critical causes of headaches. Okay? So, what I'm going to do is to introduce you to some of the critical secondary causes of headaches that you need to know. So, one of them is subarachnoid hemorrhage. So, I'm going to classify them, vascular conditions. So, subarachnoid hemorrhage, intraparenchymal hemorrhage, epidural hematoma, subdural hematoma, and even patients with stroke. Okay, even patients with stroke. And you can also have patients with cavernous sinus or cavernous venous sinus thrombosis. And you can have patients who have arteriovenous malformations and temporal arthritis and carotid or vertebral artery dissection and central nervous system infections like meningitis, encephalitis, brain abscess. All right? Okay, good. Now, there are other causes like tumors, and pseudotumor cerebri is not actually a tumor, it's a pseudotumor, right? And you even have eye conditions like glaucoma, like iritis, like optic neuritis. And then you also have some drugs, some medications, which can lead to headaches, like nitrates. So please make sure you master this. Nitrates, nitrites, monoamine oxidase inhibitors, alcohol withdrawal. Okay, and remember that I mentioned carbon monoxide toxicity or carbon monoxide poisoning. And we have endocrine causes which can lead to headaches like pheochromocytoma, even some metabolic causes like hypoxia, hypoglycemia, hypercapnia, that is high levels of carbon dioxide. We also have high altitude cerebral edema. And doctors, you know what? I'm going to quiz you on all these things today. So please don't go. I'm going to quiz you on each of these topics. And then we also have preeclampsia as well. Okay. And then we have non-central nervous system infections like focal infections, which can lead to seizures, systemic infections, sinus infections, tooth infections, that is odontogenic infections, and otitis, so ear infections. And then drug related causes like long-term analgesic use, okay, like medication overuse, monosodium glutamate, all those ones. And then we also have miscellaneous causes of headache, like if a patient has had lumbar puncture, post-lumbar puncture headaches, and hypertensive emergencies. So doctors, I'm going to start quizzing you, but the quiz we'll do will be unique. We are preparing for MCQs, right? But I also believe that if the candidate knows exactly what the condition is, the person will be able to beat any question which comes in. So the primary headache syndromes, we've already dealt with them. Migraine, tension, cluster, we've already dealt with them. Okay, so now we are going to walk through the various causes of headaches with mathematical equations. Doctors, we are going to do maths. We are going to do maths right now. So please, this one, I'm not going to provide you 4 or 5 options, because that one, you know that, okay, these are the only options and one will be correct. Now I want to know whether you know. I want to know whether you really know. So that the game is called Guess the Condition. Guess the condition. So I'm going to put the first one there. And you need to type the answer for me. The patient says that this is the worst headache of my life. There's neck stiffness with nausea or vomiting, altered mental status, focal neurologic deficits, and the patient might have will tell you that, oh, doctor, maybe a few days ago I had a milder form of headache. We call it sentinel headache. So guess the condition. What is your answer? What is your answer? What is your answer? Dr. Ronnie says SAH. Everyone says SAH. Desmond Samuel says SAH. Dr. Sukreme Cow says meningitis. No, doctor, no. This is obviously not meningitis. Dr. Saman says meningitis. No, doctor. So I like this exercise because this one you can't guess. You have to know. You have to know. And this is a good exercise. So doctors, please, I've set similar questions, about 20 of them. Do you want us to go through it then? This is not meningitis, Dr. Krenzel. You need to read about meningitis. This is not meningitis. I'm sorry. Okay. So doctors, this is the next level. This is how we're going to do the quiz. Are you okay with this? Are you okay for me to test you this way so that I will really know whether you know it or not? Because I don't want you to be guessing in the exam. So if somebody comes in and your question stem says, is the worst headache or severe headache and there's neck stiffness, and you may not have to have all the features, right? You may not have to have all the features. So worst headache, neck stiffness, nausea or vomiting, altered mental status, focal neurologic deficits with prior milder headache. The answer obviously is subarachnoid hemorrhage. So that's the first cause of headache you need to master. Subarachnoid hemorrhage. How does it present? All right? Okay, doctors, let's go to the next question. Guess the condition. The patient has headache, focal neurologic deficit, sudden onset of symptoms, altered mental status. The patient has a history of either hypertension or anticoagulant use like warfarin. What is your answer? And then you are shown this image. Ha ha ha. You are shown this image. What is your answer, doctors? You are shown this image. What is your answer? As I said today, we are not doing any guesswork. No guesswork. If you know, you know. If you don't know, you learn. Doctors, I'm waiting for the answer. So someone says hemorrhagic stroke. Yeah, kind of. Beautiful. I like this. Dr. Sabine. This is powerful. Dr. Sabine. Great, Dr. Sabine. Intracranial hemorrhage, right? Good. So what's the answer? The answer is intraparenchymal. I want to be more specific. Intraparenchymal hemorrhage. Intraparenchymal hemorrhage. So if you have a patient with headache, focal neurologic deficits, sudden onset of symptoms, the patient has altered mental status. Maybe the patient says, oh, or the history says, oh, the patient has a history of hypertension or anticoagulant use. This is intraparenchymal hemorrhage. Okay. Next question. This patient suffered a head trauma. The patient lost consciousness. The patient had temporal recovery. Okay. The patient now has sudden neurologic deterioration, and the patient has a fixed dilated pupil on the affected side. What is your diagnosis? What is your diagnosis? Oh my goodness, Dr. Ronnie, you're on a run. That's beautiful. You're on a run. That is beautiful. He says, I'm not going to mention your answer. I want others to also put in their answers. Someone also says subdural hemorrhage. So someone says epidural, someone says subdural. So doctors, you see the way the thing is curved? You see the way it is curved like that? So what's the answer? The answer is epidural hematoma. So doctors, please, this is the quiz we are doing today. I'm not even going to give you options so that you will guess. No. I want you to be able to know. So if you see this CT scan, you know that the patient has epidural hematoma. Doctors, please, can I move on? If I can move on, say yes. If I cannot move on as well, tell me no, Dr. Bonnie, don't move on. Just type your answer. Can I move on? Yes or no? Can I move on? So please, master epidural hemorrhage, intracerebral hemorrhage, subarachnoid hemorrhage. Dr. Maria, Dr. Maria says, I can't move on. Oh, Dr. Maria, why? Dr. Maria says, Dr. Bruni can't move on. Okay, so how do you determine epidural hemorrhage? Look for an image which looks like a half grapefruit. Half grapefruit. Okay. The convex nature. So that's why I put that arrow is there. Okay, that arrow is there. That arrow is there. So Dr. Maria says, Dr. Bruni, I just want to write the info. Interesting. Oh, Dr. Asma Tahir says, Dr. Bruni, don't move on. My goodness. My goodness. How can I do this? So you have somebody who has head trauma, loss of consciousness, and the patient may have recovered temporarily and then went down again, and there's sudden neurological deficits, and it looks like the patient has fixed dilated pupil, and you see a CT scan, and the CT scan, you see something like this. It looks like grapefruit, half grapefruit, half grapefruit. It looks like half grapefruit. Oh, if you see that, think about epidural hemorrhage. And if you go into our neurology portal and you also go into our emergency medicine portal, you see that I've explained this even further in there for you. Okay. Okay. So Dr. John says, everyone remember the lemon sign. So it looks like, a half lemon. Looks like a half lemon. So doctors, please, can I move on now? Can I move on now? Can I move on? Please. Can I move on? Can I move on now? Doctors, can I move on? Can I move on? Can I? Okay. Let's go to the next one. Guess the condition. Sudden onset neurologic deficits, hemiparesis, facial droop, slurred speech, vision changes with or without headache, altered mental status. What's your diagnosis? Doctors, keep inviting your friends. Keep inviting your friends to join us. Today, we are on a run. We're going to just enjoy ourselves today. I'm spending Christmas with you while we review this important neurology topic, right? So the patient has sudden onset neurologic deficits, hemiparesis, facial droop, slurred speech, vision changes with or without headache, altered mental status. What is your answer? What is your answer? What is your answer? What is your answer? The answer is just hemorrhagic stroke. This is just a stroke, especially hemiparesis and all that. Now, somebody's asking a question. Let me go back and then just read a question. Dr. Kolawole says, how is this different from subdural? So subdural is also a type of brain bleed. But this one, we are just trying to be more specific here. All right. That is it. And subdural, because I gave you that picture. I gave you that image. And that's all you needed to do. Okay. Let's move on to the next question. Guess the condition. The patient has headache on the side of the head. The patient has scalp tenderness. The patient has jaw claudication, so pain in the jaw. The patient has even developed vision loss. And on the lab, you see that the ESR is elevated or the CRP is elevated. And the patient has proximal muscle pain and stiffness. So if you are preparing for your MCCQE1 and you see a combination of this, whether you are solving your UWorld questions or you are solving your daily CDM questions or you are solving your ACE Q-Bank questions, or you're even solving the medical council's own questions which you can buy from their platform. Headache on the side of the head, scalp tenderness, jaw claudication, vision loss, elevated ESR, C-reactive protein, polymyalgia rheumatica symptoms. The patient has proximal muscle pain and stiffness. Doctors, what's your answer? What's your answer? What's your answer? Guess your condition. And the answer is temporal arthritis, right? Temporal arthritis, which goes with giant cell arthritis, temporal arthritis, giant cell arthritis, temporal arthritis, giant cell arthritis. Okay, doctors, are we good? Are we good? Can I move on? Can I move on? Uh-oh, I've made a mistake here. Okay, I should have hidden the answer, but let's continue. If you have a patient who has severe headache and there's neck pain, or severe headache with neck pain, and you are told the patient has ptosis or meiosis, okay, or the patient has tinnitus, noise in the ear, or the patient may have symptoms of a stroke, but the patient has headache with neck pain. Doctors, please think about carotid or vertebral artery dissection. Think about carotid or vertebral artery dissection. Think about carotid or vertebral artery dissection. Headache, neck pain, ptosis on one side, or meiosis, or the patient has noise in the ear and features of a stroke, right? Where there can be vision changes or speech difficulty. Think about carotid or vertebral artery dissection. Doctors, please, if you want to write it, I'll wait for you to write it before I move on. If you want to write it, I'll wait for you to write it before I move on. If you want to write it, I'll wait for you to write before I move on. Doctors, I'm enjoying today's class. Are you as well? I want to know. I'm enjoying the class today. What about you? Are you enjoying the class? I'm enjoying the class because this is, we are not in MedCognito. We don't believe in giving long, winding, no lectures. Just go straight to the point, Dr. Boone. Just go straight to the point. I'm enjoying the class. What about you? What about you? If you are really enjoying it, why don't you click on the like button on Facebook and YouTube and also subscribe to our YouTube channel, doctors? I'm enjoying the class because it's making things better and easy for me to understand, right? So someone says, will we have access to it later? Yeah, to be on YouTube, you can always go back and watch it, okay? Now, doctors, I have another question. You have another patient with headache, fever, neck stiffness. The patient all look at light, photophobia. Oh my goodness, light. I can't look at it. Altered mental status, pain or resistance when attempting to straighten the knee while the hip is flexed at 90 degrees. Yeah. What's your diagnosis? Doctors, what's your diagnosis? Headache, fever, neck stiffness, photophobia, with or without altered mental status, pain or resistance when attempting to straighten the knee while the hip is flexed at 90 degrees. What's your diagnosis? This one, if you know what the sign. Okay, so I have a question. What sign is demonstrated by pain or resistance when attempting to straighten the knee while the hip is flexed at 90 degrees? What sign is that, doctors? Tell me. What sign is that? Pain or resistance when attempting to straighten the knee while the hip is flexed at 90 degrees. So I'm asking two things here. What is the condition and what is the sign? What is the condition and what is the sign? So it looks like everybody is getting it right. Meningitis. Doctors, please keep smashing the like button. Keep smashing the like button. Keep subscribing to the MedCognito portal. And what is the sign? Okay, so it is meningitis. Beautiful. Why? In meningitis, patients will present with headache. They'll present with fever. They'll present with neck stiffness. They'll present with photophobia. They will have they may have altered mental status. And then what is the sign? The sign is the Koenig's sign. Koenig's sign. Pain or resistance when you're attempting to straighten the knee while the hip is flexed at 90 degrees. Koenig's sign. Doctors, I hope we are learning. We are learning something, right? Okay. Guess the condition. Headache, fever, altered mental status. The patient may have focal neurologic deficit, and the patient has a history of recent viral infection, or you are told that the patient has some vesicles. Focal neurologic deficits, history of recent viral infection or vesicles. What is your answer? What is your answer? Yeah. What is your answer? What is your answer? Because I could have easily put the answers there and then you guys go, okay, let me choose one because it is one of them. No, this time I want you to give me the answer. Dr. Aisha, please, it is not giant arthritis, no. Dr. Jagdeep, you got that correct. This is encephalitis. Dr. Jagdeep got it. Dr. Titilope got it. Dr. Shaza even went on to say HSV. Well, doctor, yes, HSV can lead to this, but what is the final diagnosis? Is encephalitis, right? This is encephalitis. Beautiful. So this is encephalitis. Doctors, this is how we teach when we are in our elements, right? So that you can just grasp it quickly and you move. You grasp it quickly and then you move. Okay. All right. Guess the condition. Headache, fever, focal neurologic signs. Patient has a history of sinusitis or dental abscess, or the patient had a trauma, and there is this image which has been shown you. All right? What's your diagnosis? Headache, fever, focal neurologic signs, history of infection like sinusitis, or, oh my goodness. You guys are killing it. You're killing it. Dr. Rugira, beautiful. I really like this. Everyone is going with cerebral abscess. So some are going with toxoplasmosis. No, doctors. No. Toxoplasmosis, you may be giving, a picture of somebody who is immunocompromised, like maybe an HIV patient, right? This one, headache, fever, and this one looks like just one focus. Usually with toxo, they are multiple. That's another thing. With toxo, they are multiple. This one is just one. So the answer is nothing but brain abscess or cerebral abscess. That's the answer. Fever, headache, focal neurologic signs, history of infection, okay? Sinusitis, otitis media. So look out for those ones. Ring enhancing lesion. This is cerebral abscess. Beautiful. So doctors, before we move on, my doctors drew my attention to something. Hey, Dr. Bruni, the format of the exam is changing. We want you to do something for us. I was like, okay, what do you want me to do? He said, Dr. Bruni, I know that we have classes 8 times every month, every Thursday evening and every Sunday evening. Doctors, we have more questions coming up, so don't run away. Get some orange juice and sit and let's talk, okay? So, but Dr. Bruni, we want time with you. We want time with you. We really, really want time with you. I was like, okay, sure. And they're like, Dr. Bruni, we want to continue the classes we do with all the other doctors who come to teach us. Some of them are in U of T, some of them are in UBC. So that's fine. I was like, okay. So look, because the exam is changing, come January, I want to do extra drills with you. So like the way I'm drilling you today, okay? I want to do extra drills with you. And this extra drill, it is for all the people in MedCognito. It is free. But someone also texted me that, Dr. Bonnie, I have friends who are not in MedCognito who want to also join that drill. So every month, the students themselves tell me, Dr. Bonnie, we have a weakness here. We want you to spend 6 hours every month with us. So when I was like, okay, let me look at this, and then let's break it into 2 days. So in January, we have a class coming up. It is called Med Drills. This one, it is a top-up class on everything we do in MedCognito. So what do we do in MedCognito? Every Thursday and every Sunday, we have a 3-hour class. Okay, so that will still continue. Every 2 weeks, we have mock exams. That will still continue. You still have the MedCognito portal where you can study from. That is still there. But this one is the students with me. I'm going to drill them like, the way this doctor is on the field and bam, bam, like what we are doing today. Med drills. So the med drills can take the form of what we are doing today, where you really come in and it's like a cramming session with me. And the candidate said that, Dr. Brony, the first thing we want you to do with us is ethics. So come January, we're going to do 6 hours of ethics. The notes are already ready. We've done more than 400 PowerPoint slides. We're going to go through every ethical concept you need to know. And this is on top of the ethics class you'll be doing in the regular class. And this is on top of all the ethics videos in your portal. But this time it is med drills with Dr. Brony. So med drills is, it's like if you're in the army and the captain of the army comes and he's drilling everybody. And this is both for MedCognito candidates and those who are not in MedCognito. All right. And so for MedCognito candidates, so far as you're in MedCognito, whether you registered for 1 month, if the med drill is occurring during the period you have your subscription, you get it. You can just come at any time you want. All right. You can just come. But then if you're not in MedCognito and you still want to attend these med drills, I want to make it available as well for you. So come January, please mark your calendar. Mark your calendar. January 8th, we'll have the first 3-hour session with me. This me and you. 3 hours. Then January 20th, we'll have another 3-hour session. And we're going to go through everything ethics. And that will be our med drill for January. And then after that, I'll talk to the candidates. And then they will let me know the topic or the system they think they have weaknesses in for February. Okay? Because look, we are going hard for this exam preparation. We are not joking. And we want to make it available for everybody. So for those in MedCognito, it's free. For the med drills, if you are not a MedCognito candidate, you pay for it. But if you're a MedCognito candidate, it is free for you. For the med drills, we will load the replay in your MedCognito portal. If you are not a MedCognito candidate, you will not get any recording. Please, I want to make it clear to you. Okay? And for the MedCognito candidate, you still get your live lecture recordings, your extensive study resources, which is more than 200 hours of recorded lessons, plus more than 50 hours of med bullets, right? All that one is there for you. But if you are coming from med drills alone, please, you can only attend a live session. You will not get replays. So if you want to get replays of the med drills, then you can just become a MedCognito student. And then whatever drill we do during the time you are registered, you can get it. As well, you have more than 1,000+ questions in your MedCognito portal, which you can practice on. And for the MedCognito students, you get a discounted price on your live proctored mocks. And that will start maybe in February or March, so that we can prepare well for the exam. And if you are just coming from med drills and you're not a MedCognito student, you will not get access to me on WhatsApp. I'm sorry. Okay? And the private Facebook group and the rest, you'll not get it. But if you want to just come for med drills, you can. So what I will do is you can scan the QR code if you're not a MedCognito student. If you're a MedCognito student, there's no need to worry about this. We will send you the link in your email like what we do. Doctors, are we okay? Are you excited about the med drills? Are you excited about it? Excited about the med drills? Let me know. If you're excited, let me know. If you're excited, let me know. I'm excited about the med drills. I'm excited about med drills. If you're excited about it, please let me know. And for those who want to also get a link to register for the med drills, I'm going to put the link in the comment section. So doctors, look, it is great. Why not just become a MedCognito candidate so you can get replays of the med drills and everything? But if you don't want to be a MedCognito candidate, that is fine. And you just want to come for that ethics class, that is fine. Okay? So you can scan the QR code and then you can just join us when the med drills is ready. Remember, med drills does not change the timetable. You'll still get your 8 classes a month. You'll still get access to me on WhatsApp and everything. But this is just an extra class where the captain of the ship is coming and I'm coming to drill you to prepare for the exam. Now let's move on. Back to headaches. Back to headaches. Back to headaches. Back to headaches. So, guess the condition again. Guess the other condition. This patient has headache. There's visual disturbance. There's papilledema when you do your fundoscopy. But when you do your CT scan of the head, normal imaging. But then it looks like lumbar puncture, the CSF pressure is high. Okay? CSF pressure is high. But when you do head CT scan, it is normal. The patient has headache, visual disturbance, papilledema, normal imaging, elevated CSF pressure. What is your answer? What is your answer? What is your answer? Headache, visual disturbance, papilledema, normal imaging, elevated CSF pressure. What is your answer? So beautiful, Dr. Shaza, beautiful. Pseudotumor cerebri. Dr. Irene also says idiopathic intracranial hypertension, both of them. Beautiful. Dr. Saman, no, this is not encephalitis. You know, doctors, that is why we need to make sure that our basics is strong. Our basics is strong, right? Headache, visual disturbance, papilledema, normal imaging, or elevated CSF pressure. And what's the correct answer? Pseudotumor cerebri. That's all. Pseudotumor cerebri. So please write this down. Write this down. Write this down. Pseudotumor cerebri. Yes, so somebody's asking for the med drills, for those who are not MedCognito students, how, when you scan it, there's a price. I think it's just $199, $199, and you can attend it if you're not a MedCognito candidate. But if you're a MedCognito candidate, it's free. Okay, it's free. If you're in MedCognito, it's free. It's free. So what's the answer here? Headache, visual disturbance, papilledema, normal imaging, like normal CT scan, but the CSF pressure is high, the pseudotumor cerebri. Beautiful. Oh my goodness. What have I done? Okay, this one I'll give it for free. So if you have another patient with headache, eye pain, okay, blurred vision, nausea and vomiting, and red eye, and the pupil is fixed, mid-dilated, and increased intraocular pressure on tonometry. Think about acute angle closure glaucoma, acute angle closure glaucoma, acute angle closure glaucoma, acute angle closure glaucoma. Okay. Now, guess the condition. Next question. If you have a patient, this one, I drilled the MedCognito candidates this morning. I drilled them on the WhatsApp group. Headache plus eye pain plus photophobia plus blurred vision plus circumoral redness plus a small irregular pupil. Okay, you have a patient with headache, eye pain, photophobia, blurred vision, and the patient has circumoral redness with small irregular pupil, and it is sluggish to light. What is your answer? What is your answer? Those in MedCognito are getting it right, because this morning there was a quiz and a lot of them were going with acute angle closure glaucoma. I was like, are you kidding me? And then we later found out that the answer is iritis. So if you've not voted in the quiz on MedCognito WhatsApp group, please make sure that you vote, because the answer is iritis, 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 iritis. Okay. Guess the condition. Patient has painful vision loss, which is unilateral, color vision deficiency, afferent pupillary defect, normal fundoscopy, or you can see optic disc swelling. What is your diagnosis? What is your diagnosis? What is your diagnosis? Painful vision loss, color vision deficiency, afferent pupillary defect, normal fundoscopy, optic disc. Ah, my goodness, look at Dr. Irene. She's just killing it. Dr. Irene says the answer is optic neuritis. Does anyone have any other answer? You have a patient with painful vision loss, color vision deficiency, right? Afferent pupillary defect, normal fundoscopy. Dr. Sahar says retinal detachment. No, I don't think so. The correct answer is optic neuritis, optic neuritis, optic neuritis, optic neuritis. Okay? Optic neuritis. So let me take my time and explain optic neuritis again. So look for a patient who presents with painful vision loss, color vision deficiency. Okay? Maybe the question can tell you, oh, the patient cannot see red lights properly. And then there's afferent pupillary defect and normal fundoscopy or optic disc swelling. The answer is optic neuritis. Okay, let's go with next question. Next, Dr. Irene is killing it. I'm very proud of you. And Dr. Umweza John as well. Powerful. These are all MedCognito candidates. And they are just killing it for me. It makes me happy that at least people are learning stuff. So, guess the condition. So you have a patient with headache. There is sweating. There is hypertension, which is like paroxysmal or sustained, okay? And then there's elevated catecholamines in the plasma or in the urine of the patient. What is your diagnosis? Patient with headache, sweating, palpitations, hypertension, elevated catecholamines. What's your diagnosis? I can see a lot of answers. Dr. Irene seems to be getting everything right today. My goodness, I can't just tell how you are preparing for the exam, but it looks like you are very hot for the exam. And so many people, everyone is saying pheochromocytoma, pheochromocytoma, pheochromocytoma. Beautiful. So that is the answer, pheochromocytoma. Next question. You have a headache, patient with headache, ataxia, altered mental status, where the patient started having confusion, hallucinations, nausea, vomiting. The patient even had a seizure. And then you also told that the patient just, like it happened when the patient was on Mount Everest. The patient was on Mount Everest. The patient was on Mount Everest and the patient started experiencing this. The patient was on Mount Everest and the patient started experiencing this. So someone is saying it is too obvious. Okay, the patient was on Mount Everest and the patient started experiencing this. What is the answer? The answer is HACE. HACE. HACE is high altitude cerebral edema. High altitude cerebral edema. High altitude cerebral edema. Okay, next question. This is a patient who has headache and blood pressure is above 140/90. You notice some proteinuria. You notice some swelling in the legs. Patient says that I have visual blurring and there's scotoma, flares. And then further history tells you that this patient is pregnant. What's your diagnosis? What's your diagnosis? Preeclampsia. Many doctors are going for preeclampsia. So doctors, I have a question. What are you learning from this session today? We are not done yet, but what are you learning from the session? What are you learning from the session? There's a better way to prepare for QA1, right? If you stick with the MCQs of the MCQ1 objectives, what are you learning? I want to know. Can you type your answer? What are you learning today? What are you learning? Like this whole exercise we are going through, what is it teaching you? What are you learning? What are you learning? What is it teaching you? What is this whole thing teaching you? What is the whole class teaching you? How to differentiate headache. Beautiful. Beautiful. How to differentiate headache. How to differentiate headache. Then Dr. Noel says, organized thoughts. Beautiful. How to approach headache. Doctor, remember, this is just a scratch of the surface. This is just a scratch of the surface, and we've done almost how many hours? We've done 1 hour, almost 30 minutes, right? Systemic approach, right? Beautiful. So this is preeclampsia. Okay. Next one. You have a headache, patient with unilateral pulsating headache, nausea, vomiting. The patient has photophobia. The patient has phonophobia, and there's aura. What's your diagnosis? Let's wrap it up. What's your diagnosis? 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 Unilateral headache, nausea, vomiting, photophobia, phonophobia, with or without aura. What's your diagnosis? This is very simple. This is migraine headaches, right? We've already reviewed that, so this should be easy for you. Okay, next question. Headache, which is band-like, non-pulsating, no nausea or vomiting, no photophobia or phonophobia, mild sensitivity to pressure on the scalp, neck, or the shoulders. What's your diagnosis? We are just wrapping up now. We are wrapping up. What's your diagnosis? What's your diagnosis here? What's your diagnosis? Tension headache. Beautiful, beautiful, beautiful. Next one. Severe unilateral headache. The patient has pain around the eye, autonomic symptoms like lacrimation, rhinorrhea, ptosis, meiosis, restlessness, and agitation. It's been going on for a short duration. It's recurring. It's recurring in clusters. What's your diagnosis? What's your diagnosis? What's your diagnosis? This is cluster headaches. Doctors, powerful. So I just want to share this testimony with you. So someone just texted me this morning from the UK. She's a practicing doctor in the UK, planning on coming to Canada, right? She said, Dr. Brony, I passed the QE1 exam by God's grace. I would like to express my heartfelt gratitude to you and the MedCognito team, okay, for the excellent course and the support you provided. Indeed, your well-structured materials, clear explanations, and dedication made a significant difference in my preparation and confidence. Okay, the effort you put into creating such a valuable learning experience for candidates is indeed exceptional. I would highly recommend your course to anyone preparing for the exam. God richly bless you all. And you know, doctors, this is what gives us the reason why we do it. Somebody always is, hey, Dr. Boni, why do you have so much energy? Doctor, I have so much energy because we are helping as many doctors as possible. That is it. Why do I have energy? Because when I hear something like this, it wants me to even do more for you, right? So I want you to remember that the Christmas promo is still going on, and it ends in 3 days. From now to December 31st. It's been going on for the past 1 week already. And so with all that we talked about, the med drills and everything, if you want to take advantage of it, all you need to do is to take advantage of this promo and you're good to go, right? Take advantage of this promo because this promo is only going for 1599. In January 2025, January 1st, it goes back to 2499. So doctors, this is the time. And when you get this, you get access to everything, med drills, everything. So just 1599 for 6 months, you get access to med drills, all live classes, all replays, all the supports, everything. You can even decide to pay it in installments, $299 a month or $359 a month for 5 months or $437 a month for 4 months. Doctors, this is up to you. But please remember, in January, no more stories. January 1st, it switches back to 2499 for 6 months. Okay, so this is the truth, and I'm just going to share. I'm sharing it with you so that if you want to join, this is the best time to join. And if you want to take advantage of it, this is the best time to take advantage of it. What I will do is I'm going to share the link in the comment section. So if you take advantage of this promo, you get access to all the med drills for the next 6 months. You get access to all live classes, all replays, everything in MedCognito, including the mocks in your portal, everything. So I'm just sharing the link in the comment section so you can use that to register, okay? And then people were asking about the med drills. So what I'll do is I'll take my time and explain the med drills again. I'll take my time and explain the med drills again. So in January, it goes back to 2499, but I don't want to spend time on that. For now, take advantage of the promo. Take advantage of the promo. So what is med drills? Med drills is the doctors reached out. They said, Dr. Bruni, we've been going through the classes and everything. We want to have time with you again every month. I was like, okay, let me check my schedule. So I'm freeing 6 hours every month. 6 hours, solid hours. 6 solid hours of time. And we're going to go through med drills. The med drills are dependent on what the students want to cover. Okay? So come January, the students said, Dr. Bruni, we want you to cover ethics. So the ethics notes are ready. Everything is ready. It will be on January 8th and January 20th. January 8th and January 20th. So we'll do 3 hours on January 8th. We'll do another 3 hours on January 20th. Okay? For those in MedCognito, it is free. But someone may say, Dr. Bruni, I don't want to get the whole course. I just want the med drills. Okay. So you can attend January 8th and January 20th, 6 hours with me and the rest of MedCognito candidates. But remember that you're not going to get replays of that med drills if you're not a MedCognito candidate. You're not going to get access to our portal. You will get just the link, the Zoom link, and that will be it. You come to the class and it's over. But if you want to get the med drills replay, all you need to do is just to be a MedCognito student, and all these things is given to you. For the 6 hours, it's only $199 for those who are not MedCognito students. This is for those who are not MedCognito students. Meanwhile, remember that even 1 month access to MedCognito promo is only $299. It's only $299, right? So if you become a MedCognito member, you get med drills for free. If you are not, you can pay for it, but remember, you will not get the replay. You will not be my regular student. You just come for med drills and that is it. But for the regular students, we'll keep doing the daily quizzes. We'll keep, if you have any question, you can touch base in the group and all that, right? So that's med drills for you. You'll also get access to our extensive study resources if you are the MedCognito candidate. So if you want to register for the med drills alone, you can scan the QR code and you can get in. What time will it be? It will be at 6 p.m. EST. 6 p.m. EST. 6 p.m. EST. So it will be 6 p.m., 7, 8, 9. So by 10 o'clock EST would have closed. Med drills, January 8th, January 20th. We're going for the med drills. Again, remember that the MedCognito promo is going on. From January, it changes back to $2,499. So please, doctors, that is it. If you want to take advantage, this is the time to take advantage. Or you can text me right now by WhatsApp, right now, +1 306 891 5649, +1 306 891 5649, +1 306 891 5649. Send me a WhatsApp right now and I can send you the link and you can get registered and we'll get a ball rolling. Always remember that MedCognito offers other things apart from the MCCQE1. We have an MCCQE1 promo going on till December 31st. NAC OSCE promo going on from now till December 31st. TDM promo going on from now till December 31st, right? If you want to prepare for CAMS as well, we can help you to prepare for your CAMS interview, your personal statement, one-on-one interview prep. Okay? So, doctors, what I'll do is I'll just stay on the line and I'll take questions. But then, please, reach out right now. My phone is here. Reach out. +1 306 891 5649. +1 306 891 5649. +1 306 891 5649. Send me a WhatsApp. If you want to talk to me, let me know. Dr. Bruni, I want to talk to you right away. I'll call you and then we'll talk. But what I'll do is I'm going to stop sharing the screen and I'll be here and take questions. If anyone has any question about the upcoming programs, just send a message. So he says, can you share the link including 1 month package? Okay, so that's Dr. Rugira. Dr. Rugira, please, which link specifically do you want? The link to the promo? Okay, I'll send a link to the promo, and I'll also send a link to the 1 month package as well. Let me send a link to the 1 month package as well. I'm sending a link right away. Okay, Dr. Rugira, I've sent it. Please remember, the promo goes till December 31st and it's over. Okay, so this is the time. And when you register, you can start studying with the MedCognito materials right away. Okay, any other question? Any other question? Any other question before we move on? Any other question? So Dr. Champion says, can you please show the previous slide? Doctor, please, when the stream is done, you can just go back and watch it. Okay, I'm going to keep it on YouTube and Facebook, so you can just go there and watch it. Okay, good. Dr. Rugira says thanks. Any other question? So doctors, exciting times ahead. Preparing for the MCQE1 with MedCognito has never gotten any better. This, look, it's going to just get better and better and better and better. And you really know that MedCognito is the best course for MCCQE1 exam. Okay, so any other question? If you have any question, please type it, or else I have a lot of messages coming through WhatsApp. Just text me right away, and I will help you. So if you want to get in touch with me, +1 306 891 5649, +1 306 891 5649. Doctors, the phone has already started buzzing. Okay, so get in touch. Let's get going. +1 306 891 5649. Someone says, is there a promo for 3/4 month package, please? Doc, please, why don't you send me a WhatsApp? Send me a WhatsApp and let's talk. I don't really understand that question. Oh, 3 or 4 months. So 3 or 4 months, that means you can take the monthly payments. That's 367 a month for 3 months or 4 months, and that should be fine. Okay. So Dr. Maria says, thank you, Dr. Bruni, for this live teaching. Sure, Dr. Maria, we are here to serve you. Okay. Yeah. Any other question? Any other question? Any other question? Please just send a message. Just send a message. Just send a message. Just send a message. Just send a message to me right now. +1 306 891 5649. I'm here to take your calls. If you have any concern, let's see how best we can help you. But doctors, thank you very much. It's been a wonderful day reviewing headaches. MedCognito candidates, let's continue studying in the WhatsApp group and on your portal, and let's all aim for success. Merry Christmas, Happy New Year. Make sure you take advantage of the promo, and see you during the med drills as well. Thank you, doctors. Have a good day. Bye-bye. Bye-bye.